Good afternoon, everybody. Today we're going to talk about hormone health in both men and women, and what's necessary to achieve optimum health and wellness. There are my disclosures, and today our objectives are to get a better understanding of cortisol, thyroid, vitamin D, and sex hormone physiology and metabolism, hormone imbalances that may occur throughout one's lifetime, the importance of laboratory testing and identifying and resolving hormone dysregulation, and really the impact that systems biology plays in hormone health. We're going to take a trip along the West Coast, and along this trip, you're going to meet a couple of my patients. Our journey will include a discussion of hormones important to both men and women. Those are cortisol, thyroid, and vitamin D, reproductive hormones in both men and women, and reproductive hormone imbalances that can occur along a lifespan in both men and women. Along our journey, we'll ask some of these questions. Is there a possible hormone imbalance? How do we make a diagnosis? What tests do we order? Do we need to treat the hormone imbalance? And if yes, how do we treat it? And when and how do we follow our treatment up? So let's start with hormones that are important to both men and women. And why I start with cortisol, you need cortisol to survive. It is the universal stress marker. Now, as opposed to some hormones that are made from circulating precursors like estradiol, cortisol is not one of those hormones. But when you look at the steroid pathway, it gives you the impression that cortisol is made from circulating pregnenolone and progesterone. But that's not how it happens. Here's what happens. The brain gets the signal, ACTH circulates throughout the systemic circulation, and then ACTH finds its way to the adrenal gland, and in the adrenal cortex, ACTH binds to the star protein, triggers it to bind to cholesterol, which then enters the mitochondria. And it's in the mitochondria where pregnenolone is made. So let's pause. So if you think back to the steroid pathway, circulating pregnenolone does not make cortisol. It's within the mitochondrial cell, within the adrenal cortex, that pregnenolone is metabolized. Pregnenolone then leaves and enters the endoplasmic reticulum where progesterone is formed. Progesterone leaves the endoplasmic reticulum, enters the cytoplasm, where it is metabolized to 11-deoxycortisol, which then re-enters the mitochondria where cortisol is made. Cortisol then leaves the adrenal cortex cell and circulates in the systemic circulation to do its thing. And then, over time, cortisol makes its way to the liver, where it is metabolized. Two really important hormones are the 11-beta HSD1 and HSD. 11-beta HSD1 is bidirectional. It can activate cortisol from cortisone, which is its predominant pathway, but it can also deactivate cortisol when there are times of high cortisol states. 11-beta HSD2 is unidirectional. It only deactivates cortisol to cortisone. And then in the liver, 5-alpha and beta reductase produce the metabolites that you then see in urine. So how do we translate this into clinical practice? First, we need to leave that traditional endocrinology model, which has very distinct borders of disease and no disease, and really think outside the box that the HPA axis works along the continuum. And that continuum involves both an adaptive state and a disease state. And so here are some terms that we need to be familiar with. Allostasis is the ability to achieve stability through change. Optimum health requires continual adjustments to the environment. And it's really through allostasis that the HPA axis, the autonomic nervous system, the immune system, the cardiometabolic systems protect the body by responding to internal and external stressors. The allostatic load is the wear and tear resulting from daily life and daily stressors. Long-term effects can lead to disease. Why? This results from either too much stress or from an inefficient stress management system. And then there's resiliency, which is the ability to quickly bounce back from stressful situations. It's your ability to cope. This is really dependent upon how one perceives the stressor. One's physical health and reserve play a part in this, genetics and lifestyle, and really resiliency as well as coherence requires positive experiences with rewards and a sense of meaning and purpose. And so Bruce McEwen was the first one to actually publish on this allostasis and allostatic load phenomenon. And this is just a pictorial depiction of what we just talked about. There are individual differences. It really is how we perceive the stressor. And in the backdrop, there's environmental stressors, major life events, trauma and abuse, and then the behaviors that we demonstrate and the physiologic responses that either lead to adaptation, which is what you want, or allostatic load, allostatic overload, and possibly toxic stress. Two really important phenomena that are responsible for allostatic load and allostatic overload are the sense of isolation and a lack of control. And most people attribute that to work stress. And when you have allostatic overload without adequate resources, this leads to toxic stress. When there is strong, frequent, prolonged activation of the stress response without adequate reserve. And Bruce McEwen described 4 types of allostatic load. I know this looks busy, but let's start at the top. Here's your typical stress response. It happens and it shuts off. If this inactivation is inefficient or inadequate, allostatic load or overload occurs. So there are these 4 types. For example, you have work stress, you have life stress, you have repeated stressors up and down, but you have adequate reserve. Here's an individual who has repeated stressors, for example, public speaking. They never adapt, but they continue to have public speaking, and they sort of start, as you see here, to lose their resilience and their ability to adapt. Here's the individual who has prolonged stress, either because they just have continuous HPA axis stimulation, or they have an inefficient system that can't turn off the system. For example, intense athletic training. In women who are depressed, if this happens, this can lead to decreased bone mineral density. But the bottom line is this kind of scenario leads to hippocampal damage, and the hippocampus is responsible for modulating this stress response. And if this continues over time, it can lead to exhaustion, where you have an inadequate response and compensatory mechanisms start to increase. And this commonly happens in individuals who have autoimmune diseases, right? Cortisol starts to increase. They lose their ability for self-tolerance. So how do we determine where somebody is along this continuum? Are they here where they have adequate coping skills, or are they here where they have inadequate coping skills? It leads to HPA axis, stress-induced dysfunction, and homeostatic derangement. Well, there are a bunch of validated questionnaires that you can use in your office, and I recommend getting this article where Fava et al. And McEwen was part of this, actually put together, and this questionnaire has been validated, and most of the things in this questionnaire are significant events. Excuse me. Then there are allostatic low clinical criteria which have been validated. Criteria A is the type of stress, and criteria B is how you manifest that stressor. And then when you see the patient, there are signs and symptoms. High cortisol is associated with irritability, anxiety. They can be wired and tired. They can have sleep disturbances. A lot of times they have carbohydrate and sugar cravings. And high cortisol can lead to increased blood pressure. And these carbohydrate cravings can lead to insulin resistance, both of which are risk factors for coronary disease. You have increased susceptibility to infections because high cortisol dampens Th1 helper cells. In those who are further along, you can have sleep disturbances, chronic pain syndromes, autoimmune diseases, and chronic disease syndromes. And here are some of the diseases: panic disorders, anorexia, diabetes. Central obesity is by definition a chronic high cortisol state. Pregnancy is a high cortisol state. Postpartum is where hormones fall, cortisol falls, and you can be set up in the postpartum arena if you have the genetic predisposition for autoimmune diseases. Fibromyalgia, chronic fatigue syndrome. Now, PTSD, even though they have low cortisol, they are very reactive. So they may have a reactive cortisol response. And really, there is no definitive lines. You can be in a high cortisol state in one part of your life and then a low cortisol state in another part of your lifetime. So it can occur throughout your lifetime at different points, depending on what is going on, your genetic predisposition, and your reserve. So how do we determine where somebody lives? Well, you can use saliva, you can use urine. Both offer valuable information about the HPA axis, and the two together provide the most information. Well, you can use saliva or urine to look at the free cortisol diurnal pattern. If you want to look at the cortisol awakening response, that can only be done in saliva. If you want to know about total cortisol production and metabolomics, that can only be done in urine. And did I say urine? Yeah, saliva testing is the gold standard. So if we're going to deviate from the gold standard, we need to compare ourselves to that. And the question you must ask is, has the test been validated against the gold standard? And Newman et al. Did just that, and this was published in 2020. They set out to determine the utility of dry urine to measure cortisol and cortisone metabolites, and metabolites. And what they asked two questions. Is the 4-spot dry urine representative of a 24-hour liquid urine? And can the diurnal pattern be observed in urine? 68 individuals did both saliva and urine on the same day. And what they found was that the 4-spot dry urine was a viable alternative to liquid, because liquid is the gold standard for urine. And the 4-spot dry urine is statistically equivalent to saliva. But I must point out something to you. And that is that this is not a car. This is not a car. This is all the urine in your bladder from overnight. This is all the urine between that first point and the second time you test. It includes the car, but it is by definition not a car. Whereas in saliva, you have 0.1 here, and then you have 30 minutes later, which is representative of the cortisol awakening response. Now, what is the cortisol awakening response? It's a mini stress test. Some believe it's a marker of HPA axis resiliency, and an abnormal response signals neuroendocrine maladaptation. So how does it happen? your eyes open, light hits the back of the retina, it stimulates the hypothalamic suprachiasmatic nucleus, which signals both the paraventricular nucleus, and what's very, very important, it directly stimulates the adrenal cortex so that it can get ready to release cortisol. And this results in a sharp cortisol spike as you go from conscious to alert. And there's many different ways to calculate a CAR. Here, the expected CAR is between 1.5 and 4, or 50 to 160. That's a very wide percentage. And you see here that this individual has an adequate cortisol awakening response. The most important thing about the cortisol awakening response that I can't stress enough is timing. Here is an appropriately done cortisol awakening response. There's time 0 where they sense awakening, and then 30 minutes later. If it's delayed by, say, 8 minutes, the curve shifts and your CAR will increase. If it's delayed by 20 minutes, you've now shifted your curve where the cortisol awakening response is decreased. And if you have a negative CAR, that means the patient didn't understand how to perform the test. And so let's look at an example where the cortisol awakening response can be helpful. Patient A, patient B, both don't have stellar urinary diurnal cortisol patterns. They're both low. Neither of these patients have Addison's disease. So just let me be clear. And so here, a cortisol awakening response will be very helpful. And as you see here, patient B has more resilience, has more reserve, is less further along that continuum than individual A. So you want to be much more aggressive with individual A than individual B. Now, let's look at a pattern where you have this low cortisol, and now we're going to look at metabolites. You would think that 24-hour cortisol and cortisol metabolites would all, the dials would all look to be in the same direction. When they don't point, like here, in the same direction, the first question you have to ask is why? Why is there such rapid cortisol clearance? Well, a couple of things come to mind. Hyperthyroidism, most notably autoimmune hyperthyroidism or hypothyroidism, obesity, and inflammation. Now let's look at the metabolites down here. And what you see is that all these metabolites are favoring cortisone. The liver is deactivating cortisol. Why is it doing that? It's doing that to balance cortisol and cortisone, to protect the mineralocorticoid receptor from high cortisol levels. And so you really need to look at both metabolites, the curve, to get the full and complete picture. And here, this was an individual who was on too much thyroid. And when thyroid was back down, here's what you see happens. Metabolites start to move, and they can move more slowly than, say, the diurnal curve. But what you've done is you've actually unmasked an issue. And what you don't want to do is look at this pattern without understanding this and just give the patient adaptogens, because, or licorice, you may make that patient feel worse. So it's really important, in addition to the diurnal curve, that you understand metabolomics. And let's talk a little bit about 11-beta HSD2, as we talked about. Its predominant place lives in the kidney. It is there to protect the mineralocorticoid receptor, so aldactone and mineralocorticoids can bind to it. And here, when you look at this picture, again, low cortisol, but then you look here, and even if you didn't have this cortisone, saying, wow, why is this so high? Because these should be balanced. They should be similar. You look down at your metabolites, and now you see, wait a second, really low free cortisol. It's all being shuttled. Here you see to cortisone, And now you look at the metabolites, but it's preferentially favoring cortisol. Think liver favoring cortisol. This looks like that the kidney is deactivating this high cortisol, which should be here. It should kind of mirror image or balance this to protect the mineralocorticoid receptor. So again, don't just look at a diurnal curve in isolation. Look at the patient, look at the curve, and look at metabolomics. So how do we translate this into clinical practice? Well, Stacy's a 32-year-old accountant who complains of weight gain. She has an increased BMI, increased waist-hip ratio, and she has an android body type. She has acne, excess hair growth. She complains of anxiousness, painful heavy periods when they occur, which is infrequent. She notes difficulty sleeping. She has carbohydrate cravings. She has been trying to conceive for a year and has been unsuccessful. She's on no meds, has no allergies, has no pertinent social family review of systems. She is HLA-DQ2 double allele positive, which is the most common, and DQ8 negative. So she has the genomics for celiac disease, but has yet, according to her, has any phenotypic expression, i.e. no issues with wheat or gluten. Let's look at Stacy's baseline labs. Her chemistries are normal, except it looks like here that she's a bit insulin resistant. We'll talk about her thyroid in a bit. She's inflamed. When you see a serum hormone binding globulin in either men or women that is low, think insulin resistance. Her vitamin D is low, as is her melatonin. Now let's look at her curve. Well, her curve looks kind of on the lowish side, except for this one point. We went ahead and looked at a salivary cortisol awakening response just to see how much resiliency Stacy had. And as you see here, she has an adequate cortisol awakening response. Now, because her cortisols are all low, she's not going to have this huge, robust or high CAR, but she is generating a CAR. It's adequate. So she has more resiliency than actually I thought. And so for anybody who has HPA axis dysregulation, lifestyle interventions are going to be key. It takes 45 to 60 days to make a change and about 90 days to really see the effects of that. We don't want people doing HIIT. We don't want people doing CrossFit. We want them to back down and just do some low intensity exercise like 3 to 5 times a week. Small frequent meals, which stabilizes blood sugar, whole fresh foods, high fiber, nuts and seeds, complex carbohydrates, and gluten and dairy free because they are very inflammatory. Individuals need to get 8 hours of restful sleep. They need to practice good sleep hygiene. They need to learn relaxation and mindfulness techniques, which take practice, and we must increase our positive attitudes. We need to avoid social isolation and really increase pleasurable activities. And for anybody, we want to put them on a good multivitamin, make sure they're getting adequate B vitamins, adequate C, magnesium, fish oil, zinc, and vitamin D. Vitamin D is an immune modulator. And as I tell everybody, test, don't guess. You want levels of greater than 40 for health benefits and shoot for a goal of somewhere between 50 and 80. I aim for about 60. Now, what about adaptogens? What about treatments? Well, I've outlined for you here high cortisol, mixed cortisol, and low cortisol treatments. You need to get familiar for yourself with some of these adaptogens and really get to understand them and how they interact with other medications. And again, start low, go slow, treat them as if they're a medication, and glandulars, if somebody has positive antibodies, you just need to be really careful. All right, now back to Stacy. What are we going to do? We're going to give her a gluten and dairy-free lifestyle, low-carb eating plan to include 30 to 35 grams of daily fiber And we're going to consider an elimination diet. Now, I typically meet patients where they are. She is willing to give up gluten and dairy, and I told her it needs to be at least 3 to 6 months to see an effect. That's enough for her. And we're going to try and increase her fiber. Not everybody can go from no fiber, or 10 grams of fiber to 30 to 35. It needs to be slow, or else they'll just stop. They'll get gas, they'll get bloating, they'll get cramps. And of course, we're going to give her a probiotic, omega-3 fish oil, multivitamin complex B vitamins, magnesium. And in somebody like Stacy, who is agitated, I'm going to give her some magnesium taurate. Taurine is very calming. Vitamin D, 5,000 international units a day. Her vitamin D was about 25. And the literature tells us that for every 1,000 international units you give somebody, it will increase their vitamin D 10 nanograms per mil. So hers was about 25. This will take her about 65 or 70. And I tried to talk her into IV therapy to help build redox potential. Even though she had some evidence of resiliency, we need to get her more. And as far as adaptogens, I used the combination product that had Relora, Holy Basil, and L-theanine. And to help her sleep, I gave her PS, phosphatidylserine, 300 milligrams at night, along with a melatonin troche. Remember, melatonin is a great antioxidant. It's the body's most potent extracellular antioxidant, where glutathione is the body's most potent intracellular antioxidant. And I have never in my 10, 12, 15 years of doing this ever given anybody hydrocortisone. You don't need to do that. And some key points, there's no pregnenolone or progesterone steal. The cortisol test you choose depends on the questions you're asking. Lifestyle, diet, gut health, and positive experience are all key to HPA axis resiliency. Now let's shift gears a little and talk about the thyroid. The thyroid is a flexible, adaptable, and dynamic metabolic hormone. And so we're going to ask these questions. How's thyroid produced? What factors positively and negatively impact thyroid production? How does the HPA axis and the immune system impact thyroid function? How do we assess it? And how do we treat it? Well, brain gets the signal. You need thyroid. TRH is released, binds to pituitary receptors, which releases TSH, binds to the thyroid gland, and 95% of what the thyroid gland releases is a prohormone called T4. 5% T4 is converted in the thyroid by 5-deiodinase enzymes to T3, which then binds to the cellular nucleus. But the majority of it goes to the liver or kidney, where it's acted upon by deiodinase enzymes. And note here, the 5', which leads to the active T3, is selenium dependent. And here is what I just talked about. And what I want to just point to is that optimum thyroid hormone levels need to be in the upper quartile of the reference range. We don't want to be average. We want to be optimum. And high RT3 levels, reverse T3 levels, inhibit thyroid signaling. And so this is just a nice summary for you with the references here of factors that are necessary for thyroid production. You all know this: iron, iodine, tyrosine, zinc, selenium. There are your vitamins. And then factors for converting T4 to T3. Again, you know all of these. I'm going to point to hormones here because you must have hormonal balance in order for the thyroid to optimally do its thing. Now, that doesn't mean you have thyroid disease. It just means the thyroid is an adaptable, dynamic organ. And again, here are the things that inhibit T4 production. I'm going to focus here on stress, which we'll talk about. Toxins, heavy metals, autoimmune disease, nutrient deficiency, and any chronic diseases. And decreased conversion T4 to D3. Same stuff as on the other side. However, prescription drugs impact the conversion of T4 to T3. Well, similar to the thyroid, we need to leave this traditional model of these lines of disease and think of the thyroid more on a continuum. You have adaptive hypothyroidism and adaptive hyperthyroidism. Here are two examples: obesity, low T3 syndrome, and then you can have Hashimoto's or Graves' disease. And during restful times, you can order a TSH and a T4, and that can be enough to evaluate thyroid function. But most of us don't live in a bubble. With chronic stress, inflammation, disease states, the thyroid adapts to the allostatic load that we were just talking about with HPA axis dysfunction. And this is referred to as thyroid adaptation to type 1 and type 2 allostasis. Well, what's type 1 allostasis? Energy demands exceed the sum of energy intake and energy reserve, so we don't have enough resilience. It's really important to understand that the thyroid, when it makes thyroid hormone, it uses energy. It consumes glutathione, it consumes ATP, it consumes oxygen. And if there isn't adequate reserve, the thyroid will downregulate. Chronic illnesses, exhaustion, and you see this. You see adaptive hypothyroidism or Hashimoto's thyroiditis. And in the labs, when you order thyroid labs, you're going to see low TSH, low T3, low T4, and an increased reverse T3. Well, what about type 2 allostatic load, which is on the other side of the spectrum? This is an expected increase in energy demands with adequate reserve. Thyroid hormone gently gets upregulated to meet the demands. You see increased T3. This happens in obesity. This happens with endurance activity. This happens with pregnancy. And you see this adaptive hyperthyroidism, and the labs, you'll see normal or increased TSH, increased T4 or normal T4, but most importantly, you're going to see an increased T3 and a decreased reverse T3. And now let's put this on the backdrop of what we talked about, which is the driver of homeostasis, which is cortisol. And whether you have adaptive stress-induced high cortisol and hyperthyroidism, like in obesity, or whether you have adaptive hypothyroidism with low T3 syndrome or Hashimoto's, the thyroid is going to adapt to the allostatic load that the individual faces, the goal being preserving energy. And again, here are the signs and symptoms. We talked about some of these: fatigue and depression. You may see dry skin, brittle nails, and hair loss, menstrual irregularities. And if you have extreme hypothyroidism, you can see loss of the outer 1/3 of the eyebrow, which is Queen Anne's sign. And if you put the ankle or the shin on a chair and you look at the Achilles, you'll see a slow Achilles response. Whereas hyperthyroid or high T3 can lead to palpitations and increased pulse pressure, moist palms, hair thinning, and ultimately you can lose self-regulation. And with the loss of self-regulation, you can see Hashimoto's or Graves' disease. And autoimmunity is associated with HPA axis dysfunction and thyroid allostatic dysregulation. You have this loss of immune self-tolerance. You have an aberrant response to thyroid antigens. And whether you develop Graves' or Hashimoto's depends on whether and how the adaptive immune system responds. Just as a note, Hashimoto's is the most common thyroid disorder worldwide. It has a general prevalence of 10 to 12% versus Graves' disease, which is much lower. And you all know you'll see thyroid globulin antibodies, TPO antibodies, and in Graves' disease, you'll see TSH receptor antibodies. And so how does this happen? APCs are the innate immune system. They're antigen-presenting cells, which includes macrophages, dendritic cells, natural killer cells. And I will tell you, you need to have gut dysregulation. Most individuals have dysbiosis, have a permeable gut. such that endotoxin can leak through. It puts the immune system on guard. And then you have this genetic predisposition. And then you have HPA axis stress. And whether IL-4 is stimulated or IL-12 is upregulated will either lead to Hashimoto's or Graves' disease. But now tying it back to cortisol, our high cortisol favors Th2 immunity, where low cortisol, like our Stacy, favors Th1 cells. They're more prone to autoimmunity. So in addition to assessing the HPA axis, thyroid function test, and of course the gut, are there any additional tests that we should consider when we're talking about thyroid function? And yeah, nutrition testing. Iron studies with ferritin and a first morning urinary iodine level. You do not need to stimulate people or give people iodoral. A first morning urine iodine of 100 to 300 micrograms per liter is associated with the lowest risk of thyroid disease. However, in patients who are at risk for Hashimoto's, those with low thyroid, those with gut dysbiosis, those with loss of self-regulation, and those individuals, if you give them iodine, may increase the risk of Hashimoto's. And so again, we already talked about all these things. And so what we want to add as we add to our list of treatments, we want to test, don't guess, selenium, 200 to 400 micrograms, vitamin A, again, you saw that, very important for the thyroid. It's also an immune modulator. Iodine if you need it, iron in menstruating females, to ensure adequate ferritin or iron stores, which is ferritin. And here are your optimum labs, and here are your traditional reference ranges. And just to note, TSH has a short half-life, free T4 has a long half-life, and free T3 has a one-day half-life. And these are your optimum ranges. And so now let's go back to Stacy. No one should be surprised. We looked at Stacy's cortisol. It's kind of on the lower side. She has a high nighttime cortisol, which sets her up for chronic illnesses. And she has high reverse T3, lowish TSH, lowish T4, lowish T3, and she has TPO antibodies, and she's inflamed. We'll get to her vitamin D. And so this shouldn't surprise anybody that she has type 1 allostasis. We did urinary iodine testing, it was normal. We did nutrition testing and it documented a need for increased A, B vitamins and selenium. And don't forget glutathione, very, very important. Just to note, 2 Brazil nuts or 200 micrograms have been shown to decrease TPO antibodies. And in Stacy, she didn't want to take 2 pills, so I compounded thyroid for her, and I just gave her a little bit. She didn't need a lot, just to try and get her over the hump. The enemy of good is better. Start low and go slow. And what about LDN implant sterols? Low-dose naltrexone basically resets and improves immune system modulation. You start really low at 1.5 milligrams. You titrate it up weekly or every 2 weeks to get to 4.5 milligrams, and that will help modulate that Th1 and Th2 and restore self auto-regulation. Plant sterols are known to modulate the immune system. They improve T cell lymphocyte function, Treg cell and natural killer cell activity, and really important, they dampen the antibody response and they renormalize the DHEA cortisol ratio. So key points, don't think about thyroid in isolation. Consider the HPA axis, the allostatic load and overload. Look at resiliency. Look at energy stores and redox potential. Think about the gut and the immune system. Well, what about vitamin D? Vitamin D is more than a bone hormone. Well, classically, how do we make vitamin D? We go out in the sun, 7-deshydroxycholesterol is turned into vitamin D by UV radiation. You can take prescription vitamin D2, you can take vitamin D supplements, cod liver oil, fatty fish. It then goes to the liver where the 25 hydroxylase enzyme acts. You get 25 hydroxy vitamin D. And then in the kidney, which is under parathyroid hormone control, 1-alpha hydroxylase converts 25-hydroxy-D to the active 1,25-hydroxy-D. Now, other cells have this 1-alpha hydroxylase enzyme that is not under the control of parathyroid hormone, which comes into play when we're talking about vitamin D as an immune modulator. So what about vitamin D and bone mineral density? Vitamin D levels greater than 30 is what they found is necessary for optimum skeletal health. Vitamin D promotes bone mineral density. It increases GI calcium and phosphate absorption. Low vitamin D levels decrease ionized calcium and increase compensatorily parathyroid hormone, which leads to bone resorption. And here, when you have just low vitamin D, that's what we just talked about, you get low bone mass and osteoporosis. But if vitamin D is really, really, really low, not only do you get decreased intestinal calcium absorption, you get decreased phosphate absorption, increased phosphate excretion, and bone mineralization defects, where in children this is called rickets, and in adults it's called osteomalacia. Interestingly, epidemiologic studies have documented that low vitamin D levels are associated with increased fracture risk. A positive association between high vitamin D levels have been found with greater bone mineral density. In other words, the higher your vitamin D, the greater your bone mineral density. And that higher vitamin D levels are associated with a lower risk of any fracture as well as hip fractures. Here's the problem. Randomized controlled studies have not documented the same. They documented mixed results where most document no significant benefit with vitamin D alone. In fact, the trials that did document non-vertebral and hip fracture prevention stated you needed a vitamin D level of greater than 40, not 30. And what about vitamin D and calcium? There's a marginally significant benefit. You get a 6% decrease in the risk of any fracture and a 16% decrease in hip fracture. So here are some reasonable recommendations. Maintain the vitamin D levels greater than 40 to about 60, your range of 50 to 80, and remember you need vitamin D levels greater than 40 for other non-skeletal health benefits, which we'll get to. Calcium supplementation, use dietary sources first. Then if you need, add calcium in divided doses. If you give people bolus dosing of calcium, it causes a quick rise in calcium and can lead to kidney stones, colon polyps, and cardiovascular disease. Well, what about autoimmune disease? Vitamin D inhibits Th1 cell proliferation and associated pro-inflammatory cytokine production. It is an immune modulator. It promotes immune tolerance. It blunts that loss of self-regulation. It allows for autoregulation to occur. And what about cardiovascular disease? Well, low vitamin D levels have been associated with all this bad stuff. LV hypertrophy, hypertension, atherosclerosis, myocardial infarction, stroke, thrombotic events. Here's the problem. Supplementing with vitamin D does not change cardiovascular outcomes in the studies that have been done. Why? Probably the doses were all different. The levels they strive for were all different. And what about calcium? Well, too much calcium also leads to bad things happening. Myocardial infarction, stroke, chronic kidney disease, and calcium supplementation can increase serum ionized calcium and potential major adverse cardiovascular event. That's why using dietary calcium, which doesn't do that, should be your first choice. And there's just a list. You can find the list anywhere of foods that are high in dietary calcium. Here's a study that looked at vitamin D and COVID-19, SARS-CoV-2. This was a retrospective study assessing the identified lab data that included over 190,000 patients from all 50 states with positive COVID-19, and they looked at their vitamin D status. And what they found was that there was a strong inverse relationship between vitamin D levels and COVID test positivity. Not severity of disease, just test positivity. And this was independent of race, where somebody lives, ethnicity, and sex. And what they found is that individuals who had these low vitamin D levels had a 54% higher positivity rate when compared to individuals with vitamin D levels of 30 to 40. And in fact, the risk of COVID positivity continued to decline until vitamin D levels reached approximately 55 nanograms per mil, where it started to plateau. Bottom line, serum vitamin D levels, 60 nanograms per mil about, to achieve immune adaptability and decrease disease positivity rates. And this is just, again, the immune system. Vitamin D increases deficiency, increases oxidative stress, and does all these bad things. It improves redox potential. It modulates the gut microbiome. It increases diversity. It improves permeability. Just remember, vitamin D doesn't act in a silo. You need other vitamins and minerals and glutathione and amino acids to actually optimally improve the immune system. And so now let's look at Stacy. We know she has thyroid antibodies. We see her, she has cortisol dysregulation, and she has insulin resistance. And so we are going to give her 4,000 international units a day, which would increase her vitamin D level to about, 65, and then we'll recheck it in 3 months. I always start with an increase in dietary intake, and I typically use vegetables, so we get increased fiber. I try and avoid dairy because it's so inflammatory. And so key points: epidemiologic studies support vitamin D's role. Maintaining vitamin D levels between 50 and 80 may improve bone mineral density. The probability is better with adequate calcium, and it definitely is an immune modulator. Low vitamin D levels are associated with increased risk, but studies replacing vitamin D have yet to document a statistically significant improved outcomes. That doesn't mean you shouldn't use it. You just need to understand the data. And for each 1,000 international units given, it'll increase vitamin D levels by 10 nanograms per mil. All right, reproductive hormones. Now, how are hormones made? They're all made from cholesterol via pregnenolone. This is the delta-5 pathway in both men and women. Testosterone is made in the testicular lilac cells and the ovarian theca cells. And then in the ovary, testosterone, because of higher aromatase activity, is then converted to estradiol. But what's very, very important is that the gonads do not have the enzymatic machinery to make cortisol or aldosterone. So you are not going to steal pregnenolone, you're not going to steal progesterone from systemic circulation and the ovaries and the testicles to make cortisol. And just as a note, the testes produce testosterone via 2 routes, via androstenedione and androstenedione. All right, in women, who are much more complicated, testosterone 50% is peripheral conversion. You see how complicated women are. DHEA is 25% from the ovary, 50% from the adrenals, and then 25% from peripheral conversion. And androstenedione is a 50-50, whereas men are much more straightforward. Greater than 95% of testosterone is made in the testes. DHEA is predominantly in the adrenals. Androstenedione is predominantly in the adrenals, and estradiol is made via peripheral conversion. And so if you take anything away from this section, take this away. A hormone's ultimate effect is determined by how it is metabolized. The liver is the major contributor to hormone metabolism. Most peripheral tissues have enzymatic machinery to activate and inactivate enzymes, inactivate hormones. Phase 1 SNPs will upregulate, phase 2 SNPs will downregulate, and if you're unfortunate to have SNPs in both phase 1 and phase 2 metabolism, it can lead to increased toxic intermediaries. So let's go back to Stacy. What do we see? She has increased BMI, increased waist to hip ratio. She has this android body type. She has acne. She has excess hair growth. She can't get pregnant. She skips cycles. And we see her serum hormone binding globulin is low. She's insulin resistant. Her LH is elevated, as is her DHEA. So what are we thinking? High insulin, high androgens, low serum hormone binding globulin, abdominal obesity, difficulty getting pregnant, we're thinking PCOS. These are diagnostic criteria that are still in use today. And what's the pathophysiology? Well, you have elevated insulin, leads to altered hypothalamic function, so you get FSH and LH that are not secreted properly, you get a shift towards LH, you get more androgens, ovulation doesn't occur, progesterone is low, estrogens are not opposed by progesterone, which is progesterone's primary role is to balance estradiols proliferative effects, and so you get a sense of estrogen dominance and excess estrogen. Elevated insulin leads to decreased serum hormone binding globulin, which also leads to increased free testosterone. And if you're into pictures, this is just a pictorial depiction of what we just talked about. And we're going to talk about something that a lot of individuals don't spend a lot of time thinking about, which is myoinositol and D-chiro-inositol. Both are insulin sensitizing molecules. Epimerase is the enzyme that converts MI to DCI. MI increases glucose uptake, DCI increases glycogen storage. But in the ovary, MI is very, very important. It's involved in both glucose uptake and FSH signaling. If you have a high concentration of MI, you're going to get oocyte maturation and you're going to get a mature follicle. If you don't, and DCI is elevated, you're not going to get ovulation and you're going to get insulin-mediated excess androgens. So at the same time that the ovary is really sensitive to insulin, it is immune to insulin resistance. So as we talked about, you get the shift of FSH to LH. You get no selection of a dominant follicle. It also signals and sensitizes the granulosa cells to make more androgens. Insulin resistance increases epimerase activity and increases DCI, therefore increasing androgens. Note, DCI is also an aromatase inhibitor. And so if you have too much DCI, you're not going to get the beneficial effects. In fact, you may see an increase in androgens. That's why most don't give MI and DCI. They just give MI and let the enzymes work. And so back to Stacy. Now we're going to look at a cycle map, right? She's skipping cycles. She's having difficulty getting pregnant. We want to see if she ovulates. So let's start here. Let me orient you. Our black lines are the reference ranges. Red is estradiol, blue is estrone. Again, blacks are your reference ranges. Red is beta-pregnanedione, which is the surrogate for progesterone, and blue is alpha-pregnanediol. Here you see she has an early ovulatory peak. And so if you only did a one-day test, then 7 days later would be 17, and most people do it between 19 and 21. If she did ovulate, you'd miss it. That's why cycle maps are very important. But here, you don't know. She has this small progesterone bump. It's certainly inadequate. Did she have an LH surge? Did she have an adequate LH surge? Did she ovulate? We don't know. And when we look here, we see her progesterone is low. Note, in urine, you can assess endogenous progesterone, but when somebody is on hormone therapy, all you're looking at is metabolites. All right. And you look here and you see her androgens are all high, consistent with a PCOS picture. Now, when we look at her total DHEA production, it's really high. You see she is preferentially metabolizing down that androgenic pathway. But wait a second, why isn't her DHEAS following suit? Well, when people are inflamed, sulfation is limited. And so when you see this DHEAS that is lower, but you have high total production and high 5-alpha metabolites, think inflammation, which we know because her hsCRP is elevated. And again, when we look at her testosterone, she's preferentially going down that androgenic pathway. When we look at her estrogen metabolism, which we'll talk about a little later, what I just want you to notice is that her 2-hydroxy is less than her 4-hydroxy, and her 16-hydroxy. Though 16-hydroxy is not as detrimental as 4-hydroxy, it is still estrogenic and will add to that quote-unquote estrogen dominance. What we want to do is shift her metabolism towards that 2-hydroxy. We do not want DNA adduction to happen, which would increase her risk for hormonally driven cancers. And how do we do that? We do that with methylation. We do that with IC3 and or DIM. And when we look at her methylation activity, it's low. And so what are we going to do for Stacy? We need to increase her estrogen excretion. We need to increase her 2-hydroxy pathway, and we need to increase her progesterone. We talked about dietary fiber. Sun fiber is a nice binder. It also has been shown to lower blood pressure in those individuals who have high blood pressure if you wanted a fiber supplement. Ensure optimum GI health. You don't want recirculation of estrogens. Calcium D-glucarate, 500 milligrams twice a day, will bind those excess estrogens. And we want to give her progesterone, 300 milligrams a day, days 14 through 25. That has been shown to restore ovulation. Or you can give her 200 milligrams a day. We also want to give her a Mediterranean diet, a myo-inositol. What I did leave out here is DIM or IC3. All right, Peter is a 40-year-old lawyer who has been working from home since the pandemic. He states that he can't concentrate, his work performance has decreased, and he has a foggy brain all the time. He feels isolated and has found comfort in food. He stopped exercising, gained 15 pounds, and complains of erectile dysfunction and decreased libido. His doc placed him on Clomid to increase his low testosterone, and he's miserable. Since being on Clomid, he's developed man boobs. Other than the Clomid, he's on no med supplements. His history is unremarkable. Here is pertinent labs. He too has evidence of insulin resistance. His serum hormone binding globulin is low, which goes along with insulin resistance. On Clomid, his testosterone is 900, but his estradiol is 60 picograms per mil, which is way, way too high and will negatively impact his erectile function and his libido and his sex drive. Prolactin is normal and his LH is within normal limits. So the first question we have to ask ourselves is, how do you make the diagnosis of testosterone deficiency? And what factors should you consider when determining treatment, if you're going to treat, and how to monitor treatment? Well, first of all, let's define it. It's a clinical condition characterized by low serum T. Less than 300 to 350 nanograms per deciliter, or free T3 less than 65 to 100 picograms per mil, and clinical signs or symptoms. Most common and reliable symptoms are reduced or absent libido. There are all these non-sexual symptoms, but don't forget, men can get osteopenia and osteoporosis if they're mildly anemic, because testosterone increases erythropoietin. Look at bone mineral density. You do not want men to develop osteoporosis. You want to measure on 2 morning separate times before committing to a diagnosis. Now, even though these guidelines, quote unquote, are reasonable thresholds, they're not absolutes. You need to consider serum hormone binding globulin and how sensitive the androgen receptor is. If the androgen receptor is not sensitive, you may need higher doses and higher levels to achieve success. And it's the same thing about free T3. Remember, optimum T levels, 500 to 800 nanograms per deciliter, and T levels less than 200 to 250 nanograms per deciliter. This one is associated with adverse health outcomes. Here's your goal that you're shooting for. So what factors do we need to consider? Well, this looks busy, but you want to consider prolactin, because if a guy has a high prolactin, you want to work him up. Does he have a prolactinoma? Does he have chronic renal disease? Is he hypothyroid? What about his HPA axis? If it's normal, then you're going to go look at his LH. If he's a young guy with high LH, then he's got primary hypogonadism, and he's going to need testosterone replacement. But here's where you're going to find the majority of people with an LH of less than 5. And regardless of their age, Everybody benefits from lifestyle. 8 hours of restful sleep, movement, a higher protein diet, Mediterranean style eating. You can try nutraceuticals, Urocoma, Tribulus, Testofen, and remember, zinc is very, very important in testosterone metabolism. These may not work depending on the man's testosterone level. I've not had much success with them in isolation. For a guy who's less than 55, you do not want to give him testosterone, because once you subject him to testosterone, he's going to be on it for the rest of his life. Clomid is a reasonable option. As you see, 5 to 15, 3 times a week, not 25 milligrams a day. HCG is a little harder to get, and some guys don't like to give themselves shots. And a newer kid on the block is a peptide called kisspeptin, which actually signals the hypothalamus to release gonadotropin-releasing hormone. Then you release your own LH and FSH. And in guys greater than 55, you can try all of these if you want before testosterone therapy. But in young guys, don't forget to check for heavy metals, biotoxin illness, other toxin. And if they have TPO antibodies, you want to, again, consider avoiding glandulas. All right, here are your testosterone options. You can use a patch. Not many people use a patch these days. You can use topical testosterone, 50 to 100 milligrams. If using a compounded cream, you may need a higher dose because the data tells us it doesn't absorb as well. You need higher doses that are more concentrated to achieve the same dose as Androgel 50 milligrams. And you want to keep it above the belt and rotate sides. If you're going to use an injectable, you can do it IM or sub-Q. Sub-Q is more comfortable and it's as effective. There's a lot of data around undecanoate. 1,000 milligrams initially, then it's 6 weeks, you give them a booster, and then every 12 weeks. The patient needs to come to the office for that, and men do very well on it. Cypionate is the most common, usually divided 25 to 50 milligrams biweekly, depending on what the gentleman needs, because you don't want that quick rise and fall. And pellets are a very reasonable option. Average dose is about 750 milligrams every 3 to 4 months. Don't forget to check a PSA and a direct rectal exam. You want to make sure that the PSA doesn't increase by 0.75 nanograms per mil at any point. And after 3 months of treatment, you're going to get blood for CBC, CMP, serum hormone binding globulin, LH, total T and E2, and you want urine for comprehensiveness. Remember, serum's the default, urine adds comprehensiveness. And why do you need albumin serum hormone binding globulin? Because you want to calculate free T. You don't want to directly measure it. They're not that accurate. And what about estradiol in men? Same thing as in women. Optimum is 20 to 40. You do not want high estradiol levels. You're going to give them DIM, I3C, some fiber, calcium D-glucarate. You're going to make sure they have adequate bowel movements. And if you need to use an aromatase inhibitor, DIM and zinc are both aromatase inhibitors, you can use an astrazole. And remember, don't leave them on it and forget it, because you don't want to plummet their estradiol, because estradiol is very important for bone mineral density. So again, serum's the gold standard for monitoring. Urine adds comprehensiveness. If using urine, you need to be aware of the UGT SNP, which we'll talk about later. Again, start low, go slow, avoid tachyphylaxis and side effects. You want to check labs initially every 12 weeks. You want to monitor testosterone and estradiol metabolites, very, very important. And there is a model called the saturation model that was put forth and is a widely held and believed concept, whereby that once you hit a total testosterone level of 250, the PSA is not going to increase dramatically. If it does, then you have a problem. At less than 250, the prostate is not saturated. And when it hits that 250 saturation point, you shouldn't get this increase in PSA. And so again, regardless of delivery, greater than 500, improves sexual function, body composition, and bone mineral density. Pick your choice. You want to keep your serum E2 levels between 20 and 40 for optimum benefits. And remember, serum T levels need to be greater than 200 if you have intact aromatization, and E2 levels greater than 15 to prevent significant bone loss. Hence the 20 to 40 in men. And let's look back at Peter. Well, here's his estrogen metabolism. Yes, it's very, very important to assess estrogen metabolism in men. Men get breast cancer. Men do get prostate cancer. All right, and you see here, he predominantly is metabolizing down the 1B1 pathway and the 3A4 pathway, making him very estrogen dominant. And again, we want to shift his metabolism similar to in women towards 2-hydroxy, and we want to address his methylation activity. And so what did I do for Peter? Well, we reinforced his low glycemic load diet, his Mediterranean eating style, again, moderate exercise. We made sure we increased methyl factors and B vitamins. We put him on DIM-BID and calcium D-glucarate. I did add an anastrozole, 0.5 milligram, 3 times a week for 6 weeks only. And I added kisspeptin after 6 weeks. And here's what his labs look like. His total T was 750, his free T was 250, his estradiol came down, his serum hormone binding globulin is normalizing, his LH didn't budge much, but more importantly, his methylation activity is more balanced. And now his 2-hydroxy is improved. But the 4-hydroxy is also improved. It may take a little time for you to see optimum results. This is not a failure. This means it just takes time for metabolism to shift. It's not going to happen after 6 weeks. It's going to happen much, much later. This one was done at 4 months. All right. So what about Liz? She's a symptomatic postmenopausal woman. She's got brain fog, hot flashes, night sweats. She has no energy, feels anxious. She has trouble sleeping. She's happily married, has a good lifestyle. She's got a normal body weight, exercises regularly, and I would say she probably over-exercises. She takes vitamin D and calcium and a multivitamin after a recent bone mineral density documented osteopenia. Otherwise, she's unremarkable. Her fasting blood sugar is 100. Look at this. This fasting insulin is low. This suggests that she has beta cell fatigue. She has already been insulin resistant. Her beta cells have been working very hard, and now maybe she has crossed over to the other side. Her hemoglobin A1C is creeping up towards being diabetic. Her FSH is over 100. Her LH is over 55. E2, T, and P are non-detectable using LCMS-MS, which you must use in a postmenopausal woman and for estradiol in men, because at those lower levels, that's where you get the greatest accuracy. And it's not surprising. She's had no hormones for 5 years. It's not surprising that she's osteopenic. Her serum hormone binding globulin is at the lower limit of normal. Why? She has no hormones. And her prolactin is normal. Well, how do we define menopause? It's a retrospective diagnosis, and it's defined as the time since the last menses plus 12 months of amenorrhea. Nutraceuticals, herbals have some data. Some studies suggest you get symptomatic relief, but to date, no studies have documented consistent improvement in clinical outcomes, i.e. bone mineral density, cardiovascular disease. And here are just, some of the phytonutrients that people, have documented that will decrease basically hot flashes more than anything else. And you got to eat a ton of it. I've not had success with these alone. And then here are some herbal derivatives. This is a nice article by DeFrancis who goes over all of these. And let me point out, a lot of people use evening primrose oil, which is GLA. If you use GLA without omega-3s, you're going to send this GLA down the arachidonic pathway and make it an increase or make more oxidative derivatives and increase oxidative stress. This you all know is chasteberry, which increases endogenous progesterone. But again, I've not had tremendous success with these alone. What I do know is that transdermal on the skin, vaginal estradiol, oral or vaginal progesterone, and transdermal vaginal or pellet testosterone therapies improve symptoms and clinical outcomes. And I'm not, really going to read all this to you, but just know the data is there. And so we know that they improve clinical outcomes. What doses and delivery methods do we use, and how do we monitor it? Well, all FDA-approved patches, including an ultra-low dose patch or a low dose patch, improve vasomotor symptoms, vulvovaginal atrophy, and prevent osteoporosis at serum E2 levels of 20 to 40 picograms per mil. All FDA-approved gels improve vasomotor symptoms and vulvovaginal atrophy, but they're not approved for osteoporosis prevention. And that's because when you're trying to get something through the FDA for approval, it has to be equivalent or better to what already exists. And what they found is when they compared to patches, gels required higher doses and higher serum levels of E2 to achieve bone protection. So that's why it's not FDA approved. Compounded creams probably improve clinical outcomes, minimal data. A serum E2 level of 20 to 40 or a 4-spot dry urine level of 0.7 to 1.8 nanograms per milligram is the sweet spot to shoot for in most women. Did you say urine? Yeah, I did say urine. Well, Newman et al. In 2019 published a paper that really documented statistical equivalence between serum and the 4-spot dry urine test. They looked at premenopausal women using a cycle map. They looked at postmenopausal women on a single day, and they found that it was statistically equivalent. So you can use urine to monitor estradiol therapy, and you get a whole lot more. You shoot for 0.7 to 1.8 is statistically equivalent to a serum value of 20 to 40, which the literature documents improves clinical outcomes. Well, what about progesterone? There are all the studies that document that oral micronized progesterone, 200 milligrams, 100 milligrams, vaginal progesterone, 100 and 200 milligrams, and 45 milligrams that must be given daily will protect the endometrium. Progesterone's primary role is to protect the endometrium from estradiol's proliferative effects. Notice there's no transdermal on the skin progesterone. It is not ready for prime time. 2 studies, the largest of which says, nope, didn't protect the endometrium. 1 study says it does. That's the Leonetti study that everybody cites. But even she says it is not ready for prime time. So please do not use on the skin, I don't care the dose, transdermal progesterone to protect the endometrium. You are unsure of whether that is actually happening, where here you have the data supporting you. So progesterone is probably oral, vaginal, the only HRT that can be prescribed without monitoring, as long as you follow what I just showed you was the clinical data. Oral micronized progesterone doses dependent on the E2 dose must balance, and I'll say this 100 times, E2's proliferative effects. There really are no good testing options for oral micronized progesterone. Why? We take progesterone at night. We measure in the morning. Progesterone peaks at 1 to 4 hours. So in the morning, that value is meaningless regarding are you protecting the endometrium. What is helpful in urine is metabolite testing, which can help you with pathway predominance. Vaginal micronized progesterone can be monitored in serum. Why? The vagina does not have 5-alpha or beta reductase enzymes. Whereas if you use urine and you're giving vaginal progesterone, it's going to underestimate systemic absorption because the vaginal mucosa does not have 5-alpha and beta reductase. But the bottom line is no lab test reflects progesterone's uterine effects. What about testosterone? Testosterone is safe, it's effective, it doesn't increase cardiovascular disease, breast cancer, or endometrial cancer risk. Most studies document that regardless of delivery, you want to be at the high end of the reference range to improve clinical success. Studies that document a clinical success with serum T levels that were somewhat or many times higher, that's mainly with pellets. Becky Glazer has the largest database, found no significant adverse events. However, there are some studies, and so you need to be aware that supraphysiologic serum T levels are associated with metabolic dysregulation. I personally have never found that, and partly because I monitor patients and make sure that they don't have insulin resistance. So regardless of the delivery, we just talked about it, unless you are using pellets, shoot for the upper limit of normal. You want to be optimum. You don't want to be average. If you're using a gel or a cream, the ranges, it's a wide range, 0.5 to 10. Pellet dosing ranges from 50 to 150 every 3 to 4 months. And again, testosterone, similar men, can be monitored in urine. However, similar to testosterone therapy in men, you need to be aware of the UGT SNP. And this is just a summary slide. If you want it all on one page, estradiol, if you use a patch, the typical starting dose is that should be 0.25 milligrams. In a gel or cream, it's 0.25 to 0.5. And again, gels are product specific. And for pellets, I would not use for estrogen, never. And remember to balance it with progesterone. And again, you're going to monitor after 12 weeks of treatment. And I would just use urine. That's simple. You get so much, you get metabolites. You can monitor and dose. You can get cortisol. You get a lot of information which will help you optimally balance a patient's hormones. And there it is for topical testosterone. Remember, testosterone is not FDA approved for women, so you're going to have to compound the cream. You can do vaginal. And when you're talking about vaginal hormones, remember the skin is a barrier. The vagina is a mucosa. And if you put it on the labia, it is somewhere in between the skin and a mucosa. So you just have to be cognizant of your dosing. And pellets are an excellent choice. The average dose is somewhere between 75 and 100 milligrams. Typically, patients don't need 150 milligrams. Once again, start low and go slow. You want to avoid tachyphylaxis. And here's your summary. E2 serum levels or urine levels of 0.7 to 1.8 improve clinical outcomes. T levels should reach the higher end of the reference range unless you're using pellets. TD gels and creams 0.5 to 2, vaginal 0.5 to 2, pellets 50 to 150. And remember, there are no progesterone, serum, urine, or saliva levels that accurately reflect the endometrium. You want to follow the clinical data. And finally, a hormone's ultimate effect is determined by how it's metabolized. You want to understand an individual's hormone metabolism and detoxification prior to initiating hormone therapy. Start low, go slow. And you must do ongoing risk stratification, cardiovascular risk, breast cancer risk, endometrial cancer risk, bone mineral density, which includes metabolomics in order to have a successful hormone practice. And don't treat hormones in isolation. Look at what we call the pillars of health. Address inflammation, cardiovascular risk, gut immune brain, detoxification. We talked here about these, but don't forget about insulin resistance, environmental exposures, and lifestyle is key. And remember, women and men spend a third of their lives hormone insufficient or deficient. So it's important, and we owe it to our patients to get it right. And so we're at the end of our journey, and you say, well, what happened to Liz? We didn't get back to Liz. We're going to talk about Liz in our case study. And as I always tell people, this is a great journey. It's not easy, but in the end, it'll be worth it. This has been the most satisfying part of my career. I love dilating coronaries and taking care of heart attacks, but I just put a Band-Aid on patients. This helps patients get better. And thank you. And there are slides and slides of additional references for you. The end.
Okay, are you there?
Yeah, I'm here.
Okay, so do you need to bring up your next presentation for case studies?
Yeah, I do. It's up.
Okay,
I just
you just
have
need
to
to switch
open it.
there. Okay.
So how did that go, Amy?
I thought it went great. It's a good presentation. It's strong. I probably am concerned, and I know that you didn't go long on it, but I am concerned that we put some HRT stuff in there. We'll see what he says.
Well, I
And
have
I knew
to.
you said you were going to do it, so don't worry about that. I know it's not like a big surprise to me. I knew you were going to do it, and it really, it builds that whole story of for treatment. And it seems like it would be remiss if we didn't put it in there, but let's see what he says.
Well, here's the deal, Amy. And I looked really hard for outcome studies.
Yep.
There are none. And
I know.
it would be presentation malpractice.
Right, and that's what I'm saying. I agree. I just want it'll be, and like I said, you didn't go very long, so I'm hoping he doesn't say, "Oh, I didn't want any of this," but we'll see.
Too bad. But
Yeah.
what you think of what I did with the thyroid? That's what I wanted your feedback on with the thyroid and cortisol.
I thought it was really good. In fact, when I was listening to it, I'm like, okay, you're going to do the thyroid lecture.
Oh. But the other thing is, I want to do that if I had more time, I wanted to do that for reproductive hormones, but I didn't have time.
Yeah.
I will have time for when we do Dutch University. We can make arrows and all of that and make them move at the same time. And I really like, how I did that thyroid thing?
Yeah.
I'd like to have a pic like, how we have for cortisol and estradiol and progesterone, how you make thyroid.
Yeah, we can do it for Dutch University. I mean, as long as we plan for all of that, I think the more we can explain it in that manner, I think the better, because I think those were some of the best animations we've ever created. And I think if we keep doing that for various things, I think it really simplifies and helps the teaching.
Yes, I agree. So you see why this took me so long.
Yeah, I mean, no, what I was going to say, don't worry about it. That doesn't bother me. What I was going to say to you and compliment you, and, I think every time you do a presentation, it always reminds me what just an incredible job you do putting the slides together, just, with the content. And you just do an awesome job, Dr. Saltiel.
Amy, if you want me to do that presentation for the HPO Access, I mean, I can do it. It's not, it'll be just tight with my mouth healing and everything.
Yeah.
It's really up to you. If you'd rather have me do it, I'll do it.
Well, I mean, I'm just kind of weighing the things that we have to do and getting you back to get the testosterone finished. And Dr. Hayes has it, I mean, she's got it. Although she said I think she's been involved in the whole COVID study stuff that IFM's been doing. She was funny. She said, and she's got her slide. She just said, I've just got to refamiliarize myself. She said she'd been knee deep in COVID research. So, but she was fine doing them. So let's just have her do it and just see. I mean, I'd be curious, her as a guest presenter, what kind of attendance we'd get. And plus the other thing, Dr. Saltiel, coming up, just knowing, here's what I weighed in sending that email to Dr. Hayes and this whole presentation is, we still haven't figured out exactly what the heck we're doing for PLMI, which if it's the first week of April, we got to figure that out. Second, I still have 2 webinars kind of on the dock that I just have sort of been not pushing forward with A4M, but I'm going to start pushing forward on that. And you're going to definitely be doing one of those, and we got to figure out what that is. And I'm sure it's a lot of content you already have with HRT.
Yeah.
But, so I just got to, and then plus just, moving forward with Dutch University, I just figured you've already got enough to do. And she's got these slides, and it works out fine.
Okay. All right, because I want to, for Dutch University, try and tie that whole HPA access, thyroid, HPO access, all together.
Yeah. Yeah, for certain. for
I
certain.
just love
So
that. I knew, you've never seen the thyroid stuff. That's all
no,
brand new. The vitamin D was all brand new.
and that was all a really good section too. I got the thyroid was really good. I mean, you went longer and in what I consider better detail than any of our Dutch presenters have done. So I thought it was really good.
Well, you don't have, I mean, Amy, you could tell me if it's not always. We can be honest with each other. We always have been.
No, I thought it was great. I thought it
And
was
you
great.
like my
The
outfit?
picture was really good.
You like my outfit? I mean, this is the brand new outfit that I sent you the pictures.
Yes, I did like it. I don't see you now, but I did see you this morning. I did like it, or earlier.
Okay. All right, let me pull up the other presentation.
I'd
Did
like
Madeline?
to start. I'd like to start you on camera for this other presentation too, but to quickly go off of it so we don't have any glitches.
That's fine.
Okay.
All right. The other thing is I had trouble with Dropbox this morning, so I will send you these. I wasn't not sending them to you. I will send you these.
No
Make the
worries.
corrections.
No worries.
Because I
That's
want to
totally
make
fine.
because I want to make the corrections. I could not, I mean, I could not do hormones.
I know.
How
And
do
you didn't
you,
spend, and like I said, you didn't spend a long time on them. You know, obviously we know we can, on HRT, but I'll be curious what he says.
I
I
just
gotta tell
summarized
you,
them.
I have to tell you, you do such a great job on the cases. I really think this is a model we need to get everybody, you know, more familiar to do it. You know, make it a little bit more personal, put a name to it. You know, Dr. Saxena does such a great job. Like when she does cases, she very much puts like a face and a name, even if it's not real. And I just think it comes across a whole lot better.
Yeah, actually, this guy is my friend Bill from Fort Smith,
Hmm.
who called me, and his doctor put him on Clomid, and I'm like, what the hell? But I used some other, I used the stuff we already had for Dutch.
Yeah,
Because I wouldn't have enough time. I just used his history.
yeah, that's fine.
But that's what I mean. We need to find a repository to put good
Well,
reports.
all the stuff that I looked at for you on Saturday, you know, and I mean, I know those were just the Dutch results, but you know, I was thinking, you know, not that it's a solution now, and obviously we need to keep working on this solution for case studies and get better at it. I mean, I'm definitely thinking if we can get Hillary, that's another thing that she could work on for us, is kind of building
Yes.
these stories, these cases out for us, and build this bigger repository of case studies.
Oh my God, that would be marvelous. Even if we only had her 20 hours a week, that would be
Right.
a great thing. And in whatever
Right.
systems you're figuring out to use, or on Teams, they get stored somewhere. So
Yeah,
it's not a Chinese fire drill.
Right. I think for now, you know, Teams is going to be our best way to do some of the file sharing, but I know that's definitely, I think, something on Doug's list of, you know, making sure that while we continue to work virtually, which we will continue, you know, probably well into a little bit next year, that, you know, we're doing a better job on the whole file sharing thing. You know, I was in the office yesterday and I explained to him, you know, it took us in marketing, and still, you know, I always am bugging Madeline and Winter for files and stuff like that because I don't VPN in. But it took us a while to figure out how to share files, how to do some stuff, because we work, you know, we don't work on systems like the LIMS system or in the portal or the CRM. You know, we're all about our files that we create and save and, you know, all that stuff. So I think it was a little bit more challenging for us initially when we went virtual, you know, how to get our files, how to make sure we share with each other, how we share with other departments when we have to. So, anywho.
Yeah, I mean, I am so excited about Dutch University as I was preparing this lecture. If we can teach people, Amy, how not to live in a silo, how, to say the HPA axis impacts this. Oh, I need to assess that. And if you notice, I stressed when I talked about cortisol that you can't just look at cortisol in isolation.
Right, you can't.
And that's not because I just work for Dutch. It's partly because I really believe that. And I think you can sense that I really, really believe what I say. I'm not just playing the party line.
Yeah.
Um,
Yep.
Anyway,
Okay.
all right, I'm ready. You want me to go into presentation mode?
Yeah, why don't you go on into presentation mode?
How do you like my things?
Say again.
How do you like my first slide?
I like it. Okay,
I know it's
and
not very clear. I
pop your
could have
camera
called
back
you. I could have called you and said, give me one of those things, but we're all so busy, and I know how busy you are,
to get one of what things?
to get a
Say that
prettier
again.
picture of this.
We can always help you. We're fine. We're good. You know,
I know.
you know how this is. It's like I was talking to someone and I'm like, it's great working virtually, but you end up finding yourself working 7 days a week, probably more than you did, before. Like, and on one hand, it's great because I start early and I might finish at 2 and I may get back on and work a little bit later at night. That, everything always gets done as long as you take all 7 days. Right now, at least
Yeah.
that's how I feel.
That's
So,
why do you think I do that?
yeah. Because I
But,
definitely, I start really early in the morning and have a lot of energy, but by 2 o'clock I'm tired and I sort of stop. And then I might pick up at night. I know the last couple of days I've been picking up at night, like at 4:30, 5 o'clock, and doing a couple more hours of work. So,
yeah, you need a break. Your
anywho,
brain needs
or
a break.
at least
You
another
gotta
hour.
walk outside.
Say again?
You gotta go outside. I said, your brain needs a break.
Yeah.
You gotta walk outside.
Yeah. I just need to I just kind of, too, I usually kind of just step away from the computer. So, all right.
Oh,
So
absolutely, your eyeballs.
yeah. So I'm going to go on mute and just give a pause and then go ahead and start again. And then Madeline will know where to do her editing, her magic that she does. Okay. So I'm going on mute.
Welcome back, everybody. We are going to go over in detail a female case study. So don't fret if you sort of felt lost at when I reviewed that previously. You remember Liz, she's 55, symptomatic postmenopausal woman. She's got no energy. She feels anxious. Her mind can't stop racing. She's got trouble sleeping. She has multiple food cravings. And she feels that if she doesn't eat, she'll get hypoglycemic. This primarily occurs in the AM. So that should be a signal to you, cortisol, insulin. She's happily married. She's got grown children. She exercises. And as I stated earlier, she probably over-exercises. She takes vitamin D, calcium, and a multivitamin after her primary care doc noted that she has osteopenia on a bone mineral density. Her past medical history, family history, social history, review of systems is unremarkable. Let's look at her baseline labs. Her CBC was normal, as was her chemistry. And as I noted earlier, her fasting insulin is low, which tells me that she is moving towards, again, along the continuum, towards diabetes. Her TSH tells us that her TSH is normal, but her thyroid functions overall give us a hint as to her cortisol, right? Because she has type 2 thyroid allostasis. T3 is elevated, associated with high cortisol. Her reverse T3 is low. Her C-reactive protein is elevated. She's inflamed. Her DHEAS is on the low side. Her vitamin D is normal, which is good. She's on replacement, so we're not going to change that. So what do we got? We've got a symptomatic postmenopausal female with probable HPA axis dysfunction, low DHEAS, and poor sleep hygiene. We got that from the history. She's insulin resistant and probably has some degree of beta cell fatigue. Is she going to become diabetic? Can we turn that around? She's got type 2 thyroid allostasis. We know she has osteopenia and she's an over-exercise. So what additional tests at this point do we want to do? Well, we're going to do a Dutch Plus. All right, let's start with her salivary cortisol. Now, We look here first at cortisol, and then we'll look at cortisone. Just if you just glance at it, they look kind of similar. So there's nothing crazy that we have to explain. And what I want to remind you of is that in an individual like this, whether you got saliva or urine and it looked like this, you don't need a car, right? We already know a car's not going to help you if we did urine and we saw this. Her cortisol is high. Her cortisol awakening response is really high. And then she comes down during the day, and some people would say she sort of has a mixed picture. Her melatonin is low. And now when we look here at her cortisol and cortisone, this is 11 beta HSD2 kidney. And what we see is that they're balanced. So again, they're balanced, nothing crazy to explain. But when we look here, we see she has more cortisone metabolites. So the liver is deactivating cortisol to make cortisone and then make cortisone metabolites. Why? Metabolism favors 11 beta HSD2 to protect the mineralocorticoid receptor, and we're trying to inactivate cortisol to cortisone is why you see this. And so she's going to be gluten and dairy free. We want to put her on a low carb eating plan, 25 to 30 grams of fiber a day. Now, in somebody who is hypoglycemic in the morning, that's when you want to increase their fat, right? You don't want them to have carbs early in the morning. You want to give them carbs. You need carbs because carbs feed, complex carbohydrate feed the microbiome. They're food for the microbiome, for the enterocytes, prevents gut dysbiosis, butyrate's an immune modulator. And you want to give it to them later on in the day. And as far as basic nutrients, probiotics, omega-3 fish oil, again, the same kind of stuff. Vitamin D, her I'll also give magnesium taurate, it's calming. Continue her vitamin D, but I'm going to add K2MK7. K2MK7 shuttles calcium towards the bone and away from the vascular system. So it's very, very important. And again, I talked with her about doing some IV therapy to kind of rebuild redox potential, glutathione, multivitamins, minerals. And she was willing to do that. She has the resources to do that twice a month. She would rather do IV therapy than take pills. And let's remind ourselves about cortisol, mixed cortisol and low cortisol. And we got to pick something that would be reasonable for her. And rhodiola decreases carb, good for anxiety, performance. She's got food cravings. This would be reasonable. RG3 is it's a nasal spray and it's an immune modulator, especially for people who have brain fog. And please don't forget melatonin. Her melatonin is low. And so because Liz has mind racing and she has this really high carb, I chose L-theanine and rhodiola, and I added melatonin. Number one, she needs melatonin. It'll help her sleep. And number two, again, it's the body's most potent extracellular antioxidant. And I gave her the melatonin. I compounded it in a troche because if she has a permeable gut, how much is she going to absorb? So I'm very cognizant when people have gut dysbiosis of alternative modalities such that they get what I'm giving them. And again, somewhere between 2.5 and 10, and I typically start people at 2.5 and I get them up to 5. Now, if you are looking at melatonin for cancer prevention, you need to get people up to about, 25 to 50 milligrams. And if you give them a troche, it is equivalent to, say, 10 milligrams would be equivalent to 20 milligrams. You give them 15 would be 30. All right, and then because her DHEA is low, again, I gave her sublingual drops. Again, because I think she has dysbiosis. And to balance her immune system, I put her on some Moducare. And again, rhodiola, you want to start low. People get twitchy sometimes. And you're going to slowly titrate. I typically start people at 50 milligrams twice a day, and then I work my way up as they tolerate it. All right, let's look at Liz's estrogen metabolism? Well, she has no hormones. She's been postmenopausal for 5 years, so it is not surprising. She's not making a lot of serum hormone binding globulin because she has no hormones. Her prolactin is normal. You always want to check a prolactin. All right, let's look over here. So not surprisingly, let me orient you. Here's your postmenopausal. There's your follicular range, and there's your luteal range. And all of her hormones are low. Not surprising. And so you say to me, Doreen, why are you doing estrogen metabolized when people have no hormones? Well, you can see trends that you can take advantage of such that their metabolism is improved. And as you see here, she's a little bit preferentially down this 1B1 pathway, as opposed to where we want her down the 2-hydroxy pathway. You know, you can see that her methylation activity is probably okay. It's not robust by any stretch of one's imagination. And whenever you give people hormones, they drain B vitamins. So you need to make sure they have adequate B vitamins. When we look at her androgens, let's start here at progesterone. Remember, her progesterone, when you give individuals progesterone, especially oral progesterone, what you're looking at is metabolites. You are not monitoring progesterone. You're looking at pathway preference. And what you see here is that, I don't know, does she have a pathway preference? Hard to tell, right? And then now let's come over to DHEAS. Her DHEAS is, again, we know is on the lower side. Her metabolites are pretty okay, which again, think inflammation. And her testosterone is low. Remember, before you give somebody testosterone, you need to understand how they metabolize it, and you need to look at their metabolites in deciding what dose to give them. And so now let's look at her testosterone metabolites. You see her testosterone is at the lower end of the reference range. Her DHT is also at the lower end of the reference range. You'd like her to be in the 50 to 75% if she had adequate testosterone. And as you see here, it looks like she's preferring the 5-beta pathway, but it's really hard to tell. And her epitestosterone, which we'll talk about here in a little bit, is also low. So she meets criteria for, with low serum testosterone, that's undetectable, and low estradiol and low progesterone. I mean, she meets criteria for hormone therapy, especially given estradiol and progesterone and testosterone are really important for bone mineral density. In a study by Susan Davis, when they looked at estradiol and progesterone, it increased bone mineral density. But when you added testosterone to that, it increased bone mineral density to a greater degree. So yes, testosterone is important. And what about T metabolism and excretion? I talked about this UGT thing before. Testosterone is much more complicated than estradiol. And this really pertains to men, but it's also applicable to women. And I thought this would be a nice time to talk about this. Urine testing, whether it be estradiol, testosterone, assumes normal phase 2 metabolism. And that's true for most hormones. However, testosterone is subject to phase 2 SNPs that may limit urine's clinical utility. Testosterone glucuronidation, which occurs in the liver, doesn't always happen normally. So you have to understand the nuances to be able to interpret it. And this UGT enzyme plays a key role in androgen homeostasis. And here's what happens. The hormone goes to the liver, it gets glucuronidated, and after glucuronidation, it goes to the urine. But if you have dysfunctional glucuronidation, you're going to get lower levels, or you're going to think you have lower testosterone levels than you may actually have. It may underrepresent systemic testosterone. And here is the study that everybody cites by Jacobson, where they looked at 122 Caucasian men and compared it to 72 Korean men. And they wanted to assess urinary T excretion patterns and serum concentrations in relation to UGT2B17, which is one of the SNPs. And what they found is that Caucasian males had higher serum T levels significantly, and urinary T excretion was 16 times higher in Caucasians. Serum T significantly correlated with urine T excretion in both groups. Epi-T urinary excretion was the same. So epitestosterone is conjugated by a different allele, UGT2B, than testosterone. And what they found was that UGT2B17 occurred more frequently in Korean men. So in Asian men, it occurs greater than 60%, whereas in Caucasian men, it occurs in less than 10%. In African American men, it can occur up to 10 to 15%. So you need to be aware of this when you're evaluating urinary testosterone. And so how do we translate this? First, we have to understand this. The UGT2B17 conjugates testosterone, DHT, and 5-beta androstenediol, where UGT2B7 conjugates epitestosterone and 5-androstenediol. So what does this mean? And this applies to women also. So in somebody who's got a UGT SNP, you'll see, low, like here, low testosterone, low DHT, and low 5-beta. But epitestosterone and 5-alpha will be okay. So key point, if you see epitestosterone greater than testosterone, and if DHT and 5-beta androstenediol are low, think UGT2B17. And we always check serum because serum's the default. Serum should be normal, especially if epitestosterone and these are within the normal range. In men and women, or women on testosterone therapy, serum's the primary tool. Urine is a useful adjunct. It's very, very important to do metabolite testing. Don't stop at serum. However, just be aware, in individuals of Asian descent and maybe in a small percentage of African American men and women, you may find this UGT SNP. So what is epitestosterone? I keep talking about epitestosterone. It is an epimer of testosterone. It's structurally identical, but it's not its mirror image. It is made by the testes in similar concentrations to testosterone. It's not androgenic. It is a very useful marker for identifying this SNP. So if T is falsely low, epi-T will be normal. In men, also, epitestosterone can be used as a measure of gonadal T production and gonadal suppression with higher T levels. In women, it's much more complicated. Nobody knows what to do with epitestosterone, regarding gonadal suppression or LH production. It's more to look at in women as to whether or not they have the UGT SNP.